Welcome, everyone. I'm Teresa Reed, a member of the Brews and Views Committee of the League of Women Voters of the Ann Arbor area. This is our third of 3 monthly Brews and Views on the topic of healthcare. In January, we explored the virtues of Medicare for All with Professor Eli Rubin. Last month, we met with Susan Rinkler-Cerniglia from the Washtenaw County Department of Health to learn about the department's work to keep us safe since the beginning of the pandemic a year ago, and about the country's role in distributing, the county's role in distributing the COVID-19 vaccine. Tonight, we're exploring disparities in healthcare. With the topic, should your zip code really be a factor in life and death? The US healthcare system is an inefficient patchwork of different systems that leaves tens of millions of Americans without reliable, high quality, or affordable healthcare. America spends far more on healthcare than other industrialized countries for far worse outcomes: lower life expectancy, higher infant and maternal mortality rates, 42% of cancer patients going bankrupt within 2 years of diagnosis. Overall, despite our astronomical outlays for healthcare, the US ranks 26th in the world in terms of life expectancy and quality of care. Worse than these bare facts, the US healthcare system is far harsher for some Americans than for others. Low-income Americans, immigrants, and people of color, especially Black Americans, routinely receive lower quality care or none at all. The outcomes are predictably grim. The Washtenaw County Opportunity Index shows that life expectancy in Ypsilanti's 48198 area code is 9 years less than in Ann Arbor's 48104 zip code. As we know, that's a matter of what, 5 miles at the most. Our speakers this month will inform us about disparities in access to healthcare, in quality of treatment, and in health outcomes in Washtenaw County. They'll also address the causes of these disparities, efforts being made to mitigate them, and how individuals can help redress this gross American injustice. Patricia Coleman Burns is Assistant Professor Emerita at the University of Michigan School of Nursing and affiliated faculty of Afro-American and African Studies. As a scholar, Professor Coleman Burns has focused her career on retention and successful learning behaviors of underrepresented nursing students, health disparities and social justice in patient-centered care and providers' behaviors, Black ideology, and the colored women's club movement. She's an advocate for the rights of all persons to be free from gender oppression, sexism, racism, and violence. She has served as the co-chairperson of UM's Violence Against Women Task Force, as well as serving on several advisory committees on diversity, multicultural, and women's issues. She's served on several executive boards for agencies that have provided services for those affected by domestic violence and sexual assault, including Women's Justice Center, my sister's place in Detroit in the 1980s, and of Safe House Center in Washtenaw County through 2016. Her research is on racial identity and the reduction of health disparities. Anita Hernandez, MD, is Assistant Professor and Service Director of Family Mother Baby at the University of Michigan Medical School, Department of Family Medicine. Dr. Hernandez sees patients at Briarwood Family Medicine in Ann Arbor and at the Corner Health Center in Ypsilanti. She provides full spectrum family care, including comprehensive obstetrical care, and is fellowship trained in cesarean deliveries. Her interests include providing high quality care to the medically underserved and marginalized populations, with focuses on transgender, women's, and Latinx health. She's fluent in Spanish, German, and English. She's a member of the Diversity, Equity, and Inclusion Committee for the Department of Family Medicine and works to improve gender equity and ensure departmental education on DEI topics. Those are our distinguished guests this evening. I'm so happy to welcome them. Dr. Hernandez has agreed to go first in her presentation. So Dr. Hernandez, I turn it over to you.
Good evening, everyone. I'm so pleased to be here and thank you for having me. going to go ahead and share my screen here. All right, so it should be coming up. I'll take a nod from Teresa to show that it's coming up. Okay. So Dr. Coleman Burns and I had the honor of presenting at Washtenaw Faces Race, which was a conference a few weeks ago on health disparities and how we can move forward in society as far as both health disparities and against racism. And this talk was what I presented there, and it's been a little bit modified, but I thought it would work well here. I will say that first and foremost, I'm a family physician. I'm not a researcher. I don't research health disparities, but I live the day-to-day experience of my patients and what they face. And so that's really my perspective when it comes to this. And I consider myself a pretty fierce individual advocate for my patients, and also, trying to use my own voice to make sure that we make progress forward. So like Teresa said, I'm an assistant professor of family medicine, and also a family physician at the Corner Health Center. I'm also a daughter, a sibling, a wife, and a mother of two, amongst many other identities. So to start things off today, I thought I'd just share a story. So as a family physician, we focus very heavily on our patients' stories. We are first and foremost focused on the health of the person in front of us and their context, their family, their social situation, their zip code. All those things influence how much health, influence their health in general. So we see babies, we see older people, we see people becoming mothers, becoming fathers, and it's a really honorable place to be as a physician. So in medicine, whenever we see a patient, we generally we present the history of the patient, and we do this very formulaically. So I thought I'd present a theoretical patient that I might see. The story I'll tell about this particular patient is a mix of many patients I've seen. I can't violate any privacy, so I'm not going to share any particular one patient story. But I thought I'd just share kind of an example of how health disparities present themselves in day-to-day family medicine. So let's pretend I'm in my morning clinic and I'm seeing a patient who's 64 years old. I know her very well. I've been taking care of her for the past 5 years. She originally came to me because she thought she had a urinary tract infection, but it actually turned out she'd had diabetes probably for a long time, but she'd just not come to a physician for a long time, partially because she was kind of afraid to, as many in her family had pretty severe illnesses, and she saw her parents die young. So I'm taking care of her. She's a history of diabetes and hypertension, so high blood pressure and depression. Her visit with me at 9:10 a.m. Was converted to a video visit because of the pandemic. So otherwise she would have come to the office, but she was called a week ago and told that, well, it's COVID-19, we'd like you to stay home. So log on to your computer and do a video visit, which is easier said than done in this day and age. So the backstory here, this happens quite frequently. It'll be 9:15, then 9:20 a.m., then 9:25 a.m., and she's still not arrived to her video visit, so I give her a phone call. She's in her car. She got called into work today, and we talk a little bit about her health problems today, but we decide to defer the visit because she did get called into work. We talk a little bit about her job. She works in a factory. She's afraid to go to work every day because of the pandemic. But she really can't afford not to work. As a result of a lot of people quitting their jobs, she's been needing to work extra hours, and as a result has not been taking care of herself. So we make the plan of seeing her a week later. So just a little bit more about her. When we look at social determinants of health, which really are those factors that influence health and ultimately health disparities, there are multiple, anywhere from 4 to 12, depending on what you read. And 4 of those I've listed here. So environment can be a social determinant of health, economic issues, health literacy, and family. And so for this particular patient, she lives in an area that does not have great access to affordable fresh food. The water sources are questionable. We've talked a lot about her ability to exercise so that she can better maintain control of her blood sugar and shed some of the extra weight she's gained in recent years, but she doesn't feel like her environment is safe to walk outside. She also lacks technology access, so the fact that we'd asked her to do a video visit was fairly impractical because she doesn't have reliable internet. Economic issues are another area. So she intermittently has a car. They share one car amongst their family, which is her husband, herself, and she lives with a grandchild who's expecting. They all share one vehicle. She doesn't have a living wage. She has health coverage, but it's very challenging to actually get affordable coverage for her medication. Health literacy is another area, so education and schooling, stories told by her family about healthcare and doctors, and then family issues as well. So anything from genetics to culture. And in all of those things, racism and systemic and structural racism plays into it. So an environment that might be where people are living because of redlining, historic redlining, economic, the same thing. In health literacy, where our schools are, how crowded they are, who's in the schools, a history of segregation, all those things play into how her education was growing up. And then of course, family and how her grandparents and how her parents were influenced by very blatant racism in the past, which has carried into structural racism now. So there's a theory in medicine that that racism and any of these social determinants of health can lead to chronic stress, and that in turn influences overall health. So that's the theory behind how racism can influence a patient's overall health. And then, there's a complication of everything affects everything else. So what your family member tells you about, their reaction to a medication may influence your willingness to take it. And your ability to even get that medicine at a pharmacy is very contingent on where you live. So there are lots of crossed paths here. And then you add on a pandemic and it gets even worse. So I say that just to make the point that the COVID-19 pandemic came into this context of what is already very complicated as far as health disparities go. It is highlighting and exacerbating existing disparities and not necessarily causing any new ones. The other issue with the COVID-19 pandemic is that initially when it came into the United States, and even before that, we made it a problem of others before it became our problem. And I wanted to make one thing clear is that as expressed by this quote here by Adolph Reed, a claim that Black people are especially vulnerable as Black people to COVID-19 or any contagion is as preposterous as a claim that unicorns are especially vulnerable. So the fact that we're having major disparities in the people who are suffering from COVID-19 has absolutely nothing to do with their race, but everything to do with everything else, including who our essential workers are, where people live, and how crowded their living situation is, how people get back and forth to work, all those other things that I mentioned. So just a couple of numbers for some data. So I want you to take a second and really think about the number of cases per 10,000 in July, kind of what our population of the United States looks like, and which percentage here might reflect, or which number here represents the case per 10,000 among white folk, among our Black folk, and among our Hispanic population. And so here's the answer. So in July of 2020, 28 per 10,000 cases amongst white folk, 62 among Black folk, and 10,000 among Hispanic and Latino folk in our country. And this is based on the overall US population. So here's another way of looking at it. So the gray bars there represent the share of the population. So you can see that 61% of people in the United States are considered white. Of those, they only represent 44% of the share of cases. So you can see that for Hispanics, 28% of the COVID-19 cases, but only 17% of the population. And for our Black population, 21% of share of deaths, but only 12.3% of the population. These are huge, huge disparities. And this data is from NPR. So in Washtenaw County, this is as of the end of January, and the data is fairly similar. I looked at it for last week, but this is what's happening at our county level. So you can see that our county population is 74.1% white, representing 67% of the cases and 65% of those hospitalized and 73% of deaths. But for our Black population, 12.3% of the population, 14% of cases, but 23% of deaths, which is a large margin. So Washtenaw County kind of matches up with our national data. So our healthcare system, or what we call our healthcare system, is fractured, it's unaffordable for many, it's inequitable, it's inaccessible, it's mistrusted, it's fragmented, and it has a long history of systemic racism. So I just wanted to share kind of another way of looking at equality, equity, and justice, and kind of what I mean, or what we mean when we talk about it. So equality really refers to giving everybody kind of the same box to stand on. So you're looking over the fence here at this game, and expecting that everybody kind of has an equal opportunity. Equity means that you give the supports that people need based on the needs that they have. And so in this picture, the shortest person gets 2 boxes, whereas the tall person doesn't need a box to look over the fence. And justice, you address the inequity. So the fence is blocking people's view. I've changed it to one you can see through, and now the whole system has changed. And so here is what I kind of see when we look at it within the healthcare system. So equality there on the left, and equity in the middle. This is how we kind of work within the current healthcare system, and justice there is how we should change our society. So looking at healthcare equity and disparities, it might look like providing interpreter services for a patient who has English as a learned language. And for another patient, that might mean providing transportation services and interpreter services so that they can get the same healthcare or access to healthcare as somebody else. Okay, I'm switching gears here a little bit just to talk some about how we address disparities and racism within medicine. There's a lot of work going on right now, especially since the killing of George Floyd, on actively trying to change how we do things in medicine. People are probably aware, but there's a long-standing history of mistrust that's really rooted in unfortunate studies of the past. And a really good book on the topic would be Medical Apartheid, which we'll talk about later. But one of my main loves in medicine is delivering babies. So I spend a lot of time doing obstetrical care. And in our maternal health care, there is a huge disparity for Black mothers, unfortunately. So Black mothers have a higher rate of dying in childbirth, higher rate of complications, and a higher infant mortality rate as well. And it's very unfortunate and very, very well known. So I wanted to provide an example of how racism can play into creating a disparity. So I'll spend a little bit of time here. So one of the things I do is provide cesarean deliveries for women who've had previous cesarean deliveries or need one in the moment. And so as you may or may not know, after somebody has a cesarean delivery, they can have a vaginal delivery afterwards. The main issue is that after you have a cesarean delivery, you have a scar on your uterus, and that scar could break open during the next delivery. That's something called uterine rupture, which can be very, very dangerous, but it's rare. It only happens about 0.5% of the time. And when it does happen, it's very rarely consequential. So very rarely does it cause harm to either mom or baby. But because that complication can cause severe effects, we talk to women who've had a previous cesarean delivery about their risk of that, of them being able to have a successful vaginal birth after a cesarean delivery. And there's a well-known calculator that we use to determine a woman's likelihood of success. And I've put the calculator here on that screen. So it includes maternal age. You can see height, weight, and body mass index. And then it has two questions: African American, Hispanic, and then any previous vaginal delivery, any vaginal delivery since the last cesarean, and the indication for prior cesarean. So for example, if a baby was stuck in the pelvis, that's very different than a baby who had to be delivered by cesarean because they were breech, or because there was an issue with the baby, as far as your risk of needing another cesarean. So here is where this really plays a role. So if I have a patient who comes in and she's 28 years old and she is, sorry, I keep having to move the video out of my screen, and she is has a BMI, body mass index of 31, and her last delivery was because she did not dilate all the way. If I plug her age and BMI into the calculator and put in that she is a non-Hispanic and non-African American, her calculated risk of a successful vaginal delivery is 54.3%, which is pretty good. You have a more than half chance of delivering successfully vaginally, which is way better for your recovery and way better for baby. But if I put in that she's African American, that percentage drops to 37.8%. And the problem with those numbers is that our counseling is very different depending on what number this calculator spits out. So if somebody's chance is only 1 in 3 of having a successful vaginal delivery, I may say it may not be worth the risk of attempting to have a vaginal birth rather than a cesarean delivery in a controlled environment. But if somebody's percent chance is approaching 60%, generally speaking, that's considered to be a good indicator that you can successfully have a vaginal birth and worse the risk of a potential rupture. So the issue with this calculator is that it's not clear who is it that's identifying that the patient is African American. Am I identifying that by looking at a patient? Is the patient self-identifying that? Does it matter if one parent is and one parent doesn't identify as that? It's very problematic. And the other thing to know about this, the backstory here, is that for each cesarean delivery you have, there are additional complications. So if I have a patient who had their first baby but may have 3 or 4 children, their risk of complications with each cesarean goes up significantly. So things can perpetuate over time, depending on how the counseling goes for this particular issue. So if somebody's influenced by their low risk of successful vaginal delivery and choose to have a repeat cesarean delivery, they're going to have probably another cesarean delivery for their 3rd or 4th child as well, which can influence all of those outcomes I mentioned for Black women, including hemorrhage, so bleeding, and other things like mortality. So at the University of Michigan, we had a conference amongst the obstetrician gynecologists and family medicine to try to do away with race in this calculator. Now, interestingly, Canada uses this exact same calculator, but does not include race. It has not been validated that way, but we've made the decision to go ahead and eliminate it. And now when you look at the website where this is located, which is the Maternal Fetal Medicine Network, they do make a comment that a new calculator without race and ethnicity is under development. And so just shedding a little bit of hope that we're trying to move forward, but that we're still doing a pretty bad job with perpetuating some of these disparities. So the dream, as I see it, as far as eliminating disparities, would be to provide accessible, affordable, and equitable healthcare. In order to do that, we need to consider all those things that play into the social determinants of health. We need to put healthcare centers in places where people can access them. We need to provide transportation if people cannot. We need to address literacy and language. We need to be inclusive so that people feel safe in the spaces. We need to work on quality, and we need to actively be anti-racist. So how we get there, we vote to change the system to provide justice. So the see-through fence rather than the opaque fence. And we need to pay attention to all the factors that influence healthcare and healthcare accessibility. We need to push our systems to be better and actively include voices in healthcare and healthcare leadership. So we need to put DEI at the center so that the people who are running our health systems and who are in charge of providing care reflect the population that is served. And on an individual level, reading, learning, talking, acting, and mentoring others. This is a little bit of where I got our data from and other resources that I've recommended to my resident learners and those in the previous conference.
Wonderful. Dr. Hernandez, thank you so much for that presentation. We're going to hold questions until both of our speakers have presented their work. And so, Dr. Coleman Burns, you have the screen.
Well, I hope everyone is doing well tonight. The weather has been, I think spring is here, folk. I think we can breathe and enjoy, you know, a year later, the reality of what's going on in our society. So I want to thank the League. I have a long history with the League as a young woman. I think the first time I was introduced to the League was as a student at Cass and at Cass Tech in Detroit. And Millie Jeffries was one of the most important people that I knew in that era. So it's an absolute pleasure to be back here with the League of Women Voters. It's a very exciting time for us as well, mainly because our beginnings in terms of, I mentioned in my bio that I studied the Colored Women's Club movement. And so we both began around the same time, around the issue of voting. And we are able to come together in this space because we're beginning to look at some of the serious issues that we haven't looked at in the beginning. So we started out in the suffrage movement, and we know that racism affected how we work together. But here we are again, decades later, working together to turn this society around. And I think we do a pretty good job. So the question of whether or not our zip code really should be a factor in life or death, I think that zip codes and the work around the social determinants of health are significant concepts, but I also think that it's more than just zip codes. And we're going to look at some of that as I tell my story, and as we look at some of the issues and answer the questions of why the disparities exist, especially since concepts, as Dr. Hernandez talked about, of race, they're not biological, they're socially constructed. So what is this construction that we do as a society, and how can we overcome it and break it down and then work to have better health outcomes for us all? So I suggest that in addition to looking at zip codes, that we might look at anti-Black racism, as it seems to surpass even the borders of zip codes. Not to say that zip codes aren't key, they are, but I think as well that we need to look at why doesn't it matter if you're a celebrity and you are a Black woman? So this is a picture of a hospital that in 1968, if you remember, that was the year that the Reverend Dr. Martin Luther King was assassinated, I had my appendix removed in a Black hospital in Detroit on Davison. This is Davison Street. It's called Kerwood Hospital. My appendix was removed by a Black physician who had no privileges in the mainstream hospitals like Grace, Harper, Henry Ford, etc. So you might notice that if I was whatever, I'm 73 now and will be 74 this year. And so right from the beginning, it's not a new concept. We've been struggling with this for decades, and we must ask ourselves, what can we do differently? This is a picture of the year before 1967 in the city of Detroit. And this is one of the hospitals probably receiving, or was what it was called, or Detroit General at that time. And what you begin to see is that even in my childhood, segregation, separatism was part of the policy that we experienced in healthcare. Hospitals, wards were segregated, even waiting rooms and doctors' offices. So one of the doctors that's represented in this period in 1967 had his office in downtown Detroit, and there were separate days for Black and white patients. Why? Why was that even in our lifetime? We understand that in 1968, when I had my appendix removed, I went to a hospital that was a Black-run hospital because segregation of doctors still was a key piece of information in my lifetime. In 1965, the Medical Society of the State of New York, for example, proposed that the AMA admit African-American physicians who have thus far been denied societal membership in the various societies across the country. Because you can't have credentials to major hospitals unless you have membership or unless you attend one of the approved medical centers, medical schools. And so at that time, in 1965, it was decided against including and allowing African-American physicians to have membership in the AMA. They were opposed to it. And so it was not, they weren't opposed to it. They said it was a good thing, but it was not enforced the effort to keep Black doctors out of membership in the various medical societies across our country. So in 1968, 3/5 of the African Americans enrolled in US medical schools for the class of 69 trained either at Howard University or Meharry. And again, they could not get membership in the AMA. There's no credentials in privately owned or federally supported hospitals in the US. So in this period of the women's history, and as we celebrate women, we must continue to explore the racism and the anti-Blackness, even in our own women's movement, in our own histories. I say very clearly that my last name is a hyphenated last name because many young folk don't realize when my husband and I got married in 1977, and it still is the principle today, that you get married and you take on the women, the last name of your husbands. And then once you get issued a marriage certificate, then you can change it. Well, in my day, you had to go through that process. My name after marriage became Burns. And then I had to petition the courts and go before a judge to have my name hyphenated. So we have to remember that it's many, many practices throughout our history that disadvantage us. And so one of the things that I do, and one of the things I believe that's important, is to bring that history and the long knowledge of how we got into the mess that we're in. My son was born in 1979. And as I pointed out, I was a feminist already, created the first ever course on Black women in white America in the city of Detroit at Wayne County Community College. So I knew about feminism. I knew about birthing. I knew about good, healthy practices. And my husband and I decided in that time, some of you might remember that men were not allowed in the waiting room. It was just beginning to change. And he said he wanted to be there. He wanted to cut the umbilical cord. Many of you young folk may not understand the challenges that we went through as women to have the kind of experience that we knew was valuable. So anyway, so I wanted a special delivery room where my husband could be there, where my child would be with me. But because of segregating and prioritizing the rights of one group over another, all of a sudden, the one room was taken up by a woman who identified as a white person. And so I was not given that room. And in fact, one of the things that happened in terms of the health system often being behind times is that I was put into a room. Remember the segregated wards that I talked about earlier? I was put into a room with a woman who smoked. So most of you don't remember when smoking was in the hospitals. And I had to fight for the right to have a smoke-free room. But by September of 2001, the efforts had changed, and most of us now realize that we were able to have the services of physicians like Dr. Hernandez, and we were able to have a much more humane care. So in 2001, I had major surgery, had a Black female anesthesiologist and a female physician. And so things were beginning to change. So even as things have changed, as women's rights and the care of women's bodies generally has improved, we still have not turned that corner as it relates to issues around race. I think Sandra Day O'Connor said, well, you know, in 25 years, she was talking about 2003, we should not even need any discussion around race or any discrimination or any issues around racial discrimination. I think for anything that's been in existence for over 400 years or 250 years when in 1969, or when in 2016, someone asked, what difference does race make? What do we have to lose? Why don't we just go with a principle that says race is not an issue? And predominantly Black community said we have everything in the world to lose. We were told you're living in poverty, your families, your schools are no good, you have no jobs. What do you have to lose? We have everything to lose. I think we see that today, even as we look at the Commonwealth and look at the issues of the British Commonwealth and Meghan Markle and Harry, and the whole realization that it's not just something in our past. Yes, we are working on it, but we are still living a life that discriminates against underserved people, people who live in certain zip codes, but also Black and brown bodies, and more particularly Black bodies. This is a picture, as many of you might know, of Dr. Susan Moore. This was last year. Dr. Susan Moore, a physician, an alum of the University of Michigan. She was able to understand what was going on as she got COVID. She told the physician what she needed in the language and the words and the concepts that they could understand. And she was denied the kind of care that she knew was the best care for her. She was told by the physician that he was uncomfortable with prescribing more narcotics for the pain that she was experiencing. and you can see the video, and you begin to say, well, zip codes are a key issue, but something else is in play here. Zip codes are a key issue, but we also have to look at some of the global issues that zip codes do represent across the globe. But an anti-Blackness perspective is extremely important in dealing with public health issues. You know, I think about and looking at this picture of Dr. Moore. She didn't live in an underserved zip code. When I had my appendix taken out, or when I gave birth to my son, one might consider me upper or middle class, relatively speaking, for a Black community. So we have to look at the way in which racism impacts attitudes around our health care system. Let me say what I mean by this. When we think about the issue of disparities that exist for Black and brown bodies, if it's not a biological issue, race, then what are the impacts? What are the things that influence poor health outcomes? And Dr. Hernandez has talked about all of them. Transportation, access, lack of trust. All of these are issues that impact the kind of care that not only we receive, but the access to the care that's essential for good outcomes. Let me give you an example. When you don't have, when you exclude certain people, then you don't have their genius, then you don't have their input. So many of the guidelines, the screening guidelines that are in place are normed on a majority population, and they don't often deal with those who are underrepresented, who may not even be in the research. You know, that's some of the things that happened around COVID. Were people who represented large Black communities, large brown communities in the actual trials that were done to see the efficaciousness of the COVID vaccine. And so many of the policies and procedures that are in place are not representative of these communities. And so all too often we blame the victim as opposed to looking at what it is in the system, in the structural and systemic nature of healthcare that disadvantages some people. And I always use this example. Black Panther, Chadwick Boseman, he died of colon cancer. And so the standards of screening began at age 50. He was diagnosed at age 35, I think, or some in his 30s, because he died at the age of 43. A truly preventable death is so, so sad. So he was diagnosed at 39 and he dies at 43. Same thing when you think about over and over again, why in the face of all the policies and procedures and the ways of treating Black and brown bodies do there continue to be these disparities? And I think the difference is not just in zip codes. It is in zip codes, and because they represent a kind of institutionalized racism and a kind of anti-Blackness. But what it also represents is that we are disproportionately disadvantaging patients if we don't, as Dr. Anita does, focus on the unique needs of these patients. They are unique. We are unique. We have a history of discrimination, a history of trauma, a history of mistrust, a history of not having our needs identified and met. We have high mortality rates, not because of anything biological, but also because of the way in which our issues are not addressed. With all the science we were saying as we came on this morning, or this afternoon, this evening, if we could think about it, we're celebrating 1 year of COVID and the shutdown here in the state of Michigan. In almost less than 2 weeks, most of us, the schools, were able to transform their systems from in-person education within 2 weeks to online study. And so the argument is, and one that I often give at the university, if we can turn our systems around in 2 weeks, if we have the personal will, we can do what we need to do to reduce the disparities that exist between Black and Brown and with Black and Brown bodies and the larger society. Now I'm almost finished here, so we can have some time to talk about this and look at some of the issues that affect us. But let me just talk about some key things. Distrust. The Tuskegee experiment. We came even now with the Henrietta Lacks and the taking of cells, her immortal cells that are used in every experiment in the lab. We see that often on the backs of what Blacks believe, on their own backs, that they are being used in order to benefit other communities and not our own communities. So we have to reduce that use of science to better meet the needs of those who are the least served. You know, one of the things around COVID in this past year, or as we began to do the screening, the protocols, even how we treated COVID, was not conducive to certain communities. So you had to have internet access, even now, in order to sign up for vaccines. You have to have a smartphone. You have to be digitally literate. You have to have a car right now, in many cases, to be able to drive through the parking lot to get your vaccine. So gearing the needs of people, like Dr. Anita says, is so key. What do the people need? We already know the years of distrust. So perhaps you have folk walk up, and we now are seeing many of the churches are used where people can come into the churches. Many don't have opportunities for undocumented persons to not have to show state IDs. What's important, that we vaccinate people, or that we figure out who's a citizen or who's not? That we focus on pre-existing conditions and the social determinants of health, so that we can understand what it is that holistically people need in order to have good health. We use the community-based groups, the Divine Nine, the sororities and the fraternities, the women's organizations, the churches, the Jack and Jills, the Links, all of the possible grassroots organizations of people who the community trusts to get the information out, to have healthcare providers that look like them. Now, but let me stop here by making it very clear that we have to change the actual way in which we train healthcare providers. Because in the water, in the system, are the biases, and it almost doesn't matter if you, in general, it's a little better if you have people of color as the providers. But remember, we're teaching our health professionals on a curriculum, on ideas and beliefs that are outdated, that are structurally, systemically racist in many cases. I can talk about that later, the number of studies that have been done that show when two groups of people, one Black, one white, are presented to physician and students, that in many cases, they, as we saw with Dr. Moore, they can't diagnose, given the same script, the same indicators, cannot diagnose the disease, or if they can, then the treatment is not aggressive enough. The idea that Black skin is somehow thicker than other skin, or the idea that Blacks are seeking drugs, the idea that there all of the biases that go in place, a lot of that is taught in our health curriculums. So in closing, zip codes matter. That tells us a lot about where we need to go. It also tells us that it's really important to know that race, if it is indeed a social construct, if it's not a scientific construct, that we also have to ask not only what is Blackness constructed of, we have to ask what is whiteness constructed of, and how can we return to our cultures that uplift us as a people, that keep us having the kind of history and sense of community that is necessary for us all to work together. That we see a need as a people to envision a United States where all people have the health care that they need, where all of us are able to live a productive life. There's a young woman here on our Zoom meeting tonight. She says, from the Beloved Community Initiative, she says, I'm tired of having to give my Black son the talk, my Black sons the talk. When do people who identify as white give their children the talk so that we can create an America without racism? How do we do that? How do we create an America without racism? Because you know what? We talk about the trauma that racism places on the bodies of Black and brown people. But I close with this idea. I ask you, how has racism negatively affected all of us? It is a painful thing to see pictures of children historically watching the lynching of Black and brown bodies. It is also painful to watch our children watch us abuse and disrespect any people. So racism affects us all. Disproportionately, some Black and brown bodies, but wouldn't it be a better world for all of us if we can look at us all as human beings and know that when we address the needs of the few, that we will in fact lift all of us up, that we might move into the 21st century as a very humane group, a very compassionate group of people. Let me stop there.
Thank you so much, Dr. Coleman Burns and Dr. Hernandez. It's been extremely educational to listen to both of you, and sometimes enraging. I have questions. I have some questions that I've generated. There are probably some in chat that I haven't gotten to yet, but here are some that came in before the meeting tonight. And I'm just going to let you, either of you answer it as you see fit, or both of you answer. The first one is, how do you see the role of trauma in health outcomes in this country? The person cites the ACE study. And what are your ideas on how to address that? Doctors, why don't you just leave yourselves unmuted so you can just jump in whenever you want?
You know, I think I mean, can you imagine? I was trying to share just my own life Can you imagine preparing yourself as a feminist and having done all the work to give birth to a child in a non-drug experience? And because of racism, I believe, being denied the opportunity to practice, my husband and I, for us to practice our feminism. We couldn't do it. We weren't allowed. That's traumatic. That's extremely traumatic. We can look at Meghan Markle. The woman said she did not want to live because somebody questioned the color of her baby, unborn. That's trauma.
Mm-hmm.
And as I was also sharing, it's traumatic for our fellow citizens who identify as white, who are categorized as white, to perpetuate this kind of trauma against people. How do we get up every day and say, well, that one is not worth living, or this one is? How do we do that? So I think that's extremely important. I was looking at U of M, we have, and I don't know, Dr. Hernandez, if you know about Cascade, we have it in nursing. It's the complex adverse childhood experience and complex, I forget what the aid. And so it focuses on trauma. And so we're talking about in nursing, trauma-informed care, and looking at health in terms of the long life experience, the long lived experience of patients, and not just when they show up with an acute issue, but looking at the whole role of trauma. And one of the studies showed that for underrepresented people, for Blacks, for people of color, that we live trauma daily. It's almost like experiencing post-traumatic stress disorder on a daily basis. You go into a department store, and somebody is watching you, or folks say to you that, oh, you can't afford this. That's a very traumatic inducing piece of information in our bodies that gets put on our bodies, and we have to address.
Yeah. Dr. Hernandez?
Yeah, I would say, and I think about trauma quite a bit when I listen to my patients' stories, and the adverse childhood experiences that affect everybody are very, very real, and they're very lived experience. I think one of the issues that I have with how our system handles patients sometimes is that trauma can definitely inform how somebody reacts within the system. If they're told bad news, if they're not seen on time, if you're living a daily experience where you're feeling not valued, you may get angry much quicker. And I think there's so much emotion that's a part of that trauma experience that we don't do well addressing, that we have to do a better job of doing in general. So it's definitely something that we think of every day, and it influences, I showed the picture of the chronic stress and how that influences health, but that's a very big player when we're looking at the chronic stress in someone's life and how that influences their overall health. A huge player. And not to mention that our mental health system is pretty awful, and we don't do a very good job in helping people figure out how to navigate their traumatic experiences and build, we can talk all day about resilience, but we have to change the system too. But on an individual level, it's so important to help people face their daily traumas and be able to get through them and build their own resilience and empower them to face the world. So.
Yeah. Dr. King talked about, historical trauma, and, Dr. Coleman-Harris, you mentioned seeing images of children watching lynchings. And of course, that's there's one cost of that to white children, and there's a completely different cost of that to Black children, or mixed race children. And he spoke so eloquently about the inherited long-term generational trauma that that all African Americans, really all people of color, especially African Americans, experience, and how that compounds difficulties. Can either of you speak to what this ACE study is, ACE study? I think there was something in chat about it. Are you familiar with it?
It was put in chat, I think.
Okay.
It's the, and what I was saying, in nursing, we have our use of ACE is called Cascade. And for us, it's called the Complex Adverse Childhood Experience and Complex, I forget, approach to trauma. So we use the ACE model. There's a whole group. We did 3 years now ago. We looked at Childish Gambino, and we did the movie, not a movie, the video. And what he had captured was all the trauma and all the shootings and all the, we just experienced this past year more of the images, not just the strange fruit that Billie Holiday talks about, the lynching bodies hanging from poplar trees, but we experienced 8 minutes and 46 seconds knees on somebody's neck. What does my 8-year-old grandson think about that?
Yeah.
What are we saying to him, or my son who's 41, or me? So I think that this trauma, and in the chat, someone put it reduces one's, the scale can tell you the amount of years you lose because of the trauma that is perpetrated on our people.
Yeah.
And yet we know that the opposite is longevity. That when you remove societies that have less of this kind of trauma, they're not many, but they live long, peaceful lives. And couldn't we do that here?
Yeah. Well, I think it was you, Dr. Holman Burns, who mentioned a friend or friends who are tired of giving their Black sons the talk.
Yes.
And I can only imagine how difficult that is, and asking, when are white parents going to give their kids the talk?
Yes.
And I think that was such an interesting question, to turn that around and say, what's the responsibility of white people, or people who are identified as white, in terms of educating their own children about what children of color experience? I think that's just a great question.
Yes, that's Dr. Sakita Lewis Johnson. She's a nurse, and she's online here. And when she raised that question, it made so much sense. Why are my kids the one I have to sit down at the table and tell them to put their hands on, what is that, one and whatever that is? Yeah. Why are my kids the ones that are told, we saw the movie, what is it? The Hate You Give, Hugs, The Hate You Give. Why are we in a society where you would assume in driving while Black, or walking while Black, or running through a neighborhood, that your life was at risk? Yes, so when are we as a community going to, all of us who are conscious, because everybody doesn't want to do this kind of work that we're talking about, when are we going to give all of our children the talk,
right,
that we might change the future?
Which leads me into a question for Dr. Hernandez. You mentioned in your talk remarks about looking at the medical system and all systems actually through an anti-racism lens. And I'm reading that book right now by Ibram Kendi. And I'm sure a lot of people on the call have been reading that book or have it in their queues. Can you talk about, I personally find the concept entirely understandable, like anti-racism, but sometimes in practice, it's a little hard to grasp, like, or just hard to think how it works throughout your life, throughout all systems. Can you, either one of you, speak a bit to what does anti-racist medical practice look like? Not colorblind, everybody wanted to be colorblind for a couple decades there. And then realize that's not the answer. But what does it mean to be anti-racist in medical practice and education?
Yeah, I gave the example of the calculator that has the roots of using race in an outcome where race has absolutely nothing to do with biology, but yet it's been perpetuated throughout time with this calculator. So for me, and the concept of anti-racism, as somebody who is identified as white or Hispanic, depending on the context, I can walk through life and not think too much about racism on a day-to-day basis, but I have to be actively anti-racist and realize how much of it is in everything that's done in medicine, from the way our waiting room is set up, to the way somebody answers the phone and speaks to patients on the phone just based on a name they see. There are tons of examples, and unless you're aware, unless you bring that up into your consciousness, you can basically walk through your day-to-day life blind. And so, we're trying, in other examples would be, now we're requiring unconscious bias training for all of our new residents and our entire faculty. We are doing walkthroughs with both a group of patients and with our staff, and trying to include all voices that we can in walkthroughs, and how our clinic is set up, how welcoming it might feel. So I think there are many examples of how to do that actively, but because we are able to ignore it, it's all the more reason why we have to be conscious and aware of it on a day-to-day basis.
Yeah. Dr. Coleman Burns, you might have a comment on this too. I mean, it seems to me there are questions about what are the best practices in terms of eliminating, or at least starting to eliminate racist beliefs and practices in the medical system. And that implicit bias training, I know that that's happening, and I wonder what you're seeing in terms of receptivity on the part of the faculty and students. Is that an easy sell, or is that something people are more people rolling their eyes and, oh God, more, or how are you finding that working?
So I think a couple of things, like my own background is that I've been dealing with these issues since the 70s as a professor. They've been in existence if we go back to the Harlem Renaissance, if you go back to post-Reconstruction. So it's not a new thing. So why is it so hard to get traction and to move forward into the future? So I think I mentioned that it's actually in the water. It is, when you think about what racism is in the United States and globally, it is the belief that one race is superior to the other, to others. It's the belief that there's a certain privilege that comes along with that identity. So to address that, we have to look at a world that's not a zero-sum world. If I have good health, that doesn't take anything away from anybody else. In fact, it'll make it, obviously with COVID, it would make it better if all of us were healthy and we wouldn't be spreading this virus around. It means understanding that one group of people are not better than another, that we don't have to deny care to other people. I use the example of, my favorite example is also in terms of the research, in terms of what goes into the curriculum, what goes into the procedures and policies and protocols that address the needs of people that Dr. Anita was talking about a minute ago. So I use the seatbelt example. When we started out, it was legally, you legally had to wear a seatbelt because you could get a ticket if you didn't have your seatbelt on. But in the beginning, because they only included the 62nd percentile dummy, which was like a male 5 or 6 feet weighing 160, everybody else was dying. So when you included women, you know, dummies that were the sizes of women, the sizes of children, your science changed.
Right.
Then people weren't, you know, I remember the first thing they started doing is the seat belts on the wall would come down, because I'm 5'2". Under the old system, I'm dead. And if you were pregnant or a child, you're dead.
Yeah.
We can learn from that. Healthcare and the research that's related to health ought to include a diverse group of people. We cannot set protocols, procedures, policy on one privileged group, on the norm, the majority. The rest of us are dying.
Yeah. And it has to include people, a diverse group asking the questions, framing the questions, not just as subjects, but framing the questions.
Absolutely. Being the scientist, being in the operating room, being in the clinics, doing the work, and then listening to them.
Yeah.
Because many of these, you know, listen.
Right. Somebody had put in a question earlier, and I'm going to ask Shelley or Rena if you, I'm not looking at the chat. I can't see it right now because I'm in a document and the screen. So if there are questions in the chat, please break in and ask them. I have another question from earlier. Is Washtenaw County hiring trained community health workers to help address these inequities in healthcare and health? Does either of you know?
I don't know offhand, but I do know that from a county level and from a systems level, trying to make sure there's equity in vaccine delivery is very much on everybody's priority list.
Very high, yeah.
So I don't know about the hiring, but I have been privy almost 24/7 now in the Black community. There are nothing but get the vaccine. There are all of these healthcare providers. I mean, you see it, I get it from my sorority, I get it from my church, I get it from Kamala Harris. So there is a sense of there being trusted community workers. I don't know whether they're getting paid,
Right.
you know,
Right.
but yeah, we know that's a tried and true method, that people who are committed to the community and are trusted in the community and have been trained and have the correct education are some of the best people to get the word out.
Yeah. And in your experience, that is getting out.
Yes.
That's good. All right.
Yeah. 24/7 we have it.
Okay, good. It was like in October, it was like 24/7, vote, 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 right?
Yes. Same structure.
Yeah.
Absolutely. The same structure. And the wider community can learn from these communities. Grassroots organizing, we know how to do it. We've been doing it for years. There was a question that Dr. Sakita did ask about, she wanted to point out in chat, the indigenous people of this land often get left out of the conversation of trauma, and their experience should be included in how trauma has impacted health disparities as it relates to indigenous populations. One of my mentees now, he was the chief executive officer in California nursing. He is now on a Navajo reservation doing his service there. because Dr. Sakita, he recognizes that there is a lot to address in terms of also looking at culture. You know, we've talked about past histories of discrimination, but to include a people's culture and the understanding of how they're structured and meeting the health needs is a key factor as well.
You know, I feel like Dr. Coleman Burns, you have referenced several times without saying the name of the book, The Sum of Us, Heather McGhee's book. And maybe you've been talking about this for a long time. Her work just came out like a few weeks ago, but her a brilliant book and history on, you know, first of all, how race has been constructed like quite consciously in early America, and then also how it quite, not metaphorically or not like quietly, but often explicitly and blatantly hurts everybody, racism.
Yeah.
And it's really an amazing book that I highly recommend to everybody, because it really gets at that very point.
Will you put it in chat for folk, or
Sure.
have someone else put it in chat for?
Okay, if Rena or Shelley, if you put it in chat, it's The Sum of Us by Heather McGhee, and it's MCGHEE is Heather McGhee. She was the CEO of Demos organization for quite some time. All right, I want us to close on time. Does either of you have anything left to say? Any questions we should have asked that didn't get asked?
There's a question in chat. I do want to underscore, you know, are there good models? Are there equity models? And I said in my presentation, or maybe I didn't hit it strong enough, it's amazing to me how the historically Black colleges and the Hispanic facing colleges and universities, somehow they are able to turn out all of these fantastic physicians and to meet the need. There's something there.
Mm-hmm.
And I was saying in a meeting prior to my coming here around public school, you know, when people feel good about themselves, when you do the opposite of traumatize people, when people understand their own genius, when they understand the significance of their own cultures and how their mothers and their fathers and their grandparents, all those people were meaningful, as opposed to trying to wash them away or ignore them or deny that they ever existed, changing names, changing cultures. Somehow that diminishes people. And so I think if we have some equity models, they are listening to the communities and cultures that have brought us thus far. How after 400 years are people who are only 10% of a population still here? Some resilience is there, and we should learn from that resilience.
The strengths-based model.
Yes.
Right. As Yodi Mesfine Johnson, some of you know her, she's the CEO of the new organization here, I mean, NEW, Nonprofit Enterprise at Work, said in an extraordinary meeting today, she said, you know, our story did not begin in pain. It began in joy in our homelands. You know, so I just thought that was so beautiful. And just speaking to that strengths-based focus, which one more quick question, maybe it's probably not quick, but I do want to, it ties exactly into that thought. And that is that is how we're so reliant on the medical model and thinking about people's, thinking about health generally. Do you want to speak to that quickly, either of you?
You will notice I never use the word medical. I love my sister, Dr. Hernandez, but medicine is not the beginning and end of health. It is one discipline. There are other so we have an interprofessional model, you know, nursing. My son is a doctor of physical therapy, of pharmacy, of dentistry. And when we move beyond a disease-specific model to a birth to death model of life and health,
Yeah.
yes.
Right.
I was going to comment, I think this ties in well to the last question that of where good practices for medical equity are in place. There are two places I've worked where I've seen the system work really well, and they have to do with wraparound services.
Mm-hmm.
As a medical provider, I know what medicine would probably work best for your diabetes, but I am not a social worker, and I am not a nurse, and I am not a priest or an elder or your trusted auntie. Sometimes they can fill those roles in, but very rarely. And so those two places, one is the Corner Health Center, which has on-site maternal infant health program for pregnant mothers, often who are young and just learning how this motherhood thing works. The nurse there contacts those patients basically on a weekly basis, becomes their navigator through the whole pregnancy. They get social work services, nutrition. We teach them about baby care. The infants are followed at the Corner Health Center too. We talk about early literacy. So it's more than just, is the newborn gaining weight, or, did mom stop smoking in her pregnancy? There are many, many other factors in that. And the other place is I spent a month in residency working in Southeast Alaska in the Southeast Alaska Regional Health Consortium, which is a Native American group up there. And that service also is wraparound that included elders in the community, that included, and it was basically a community health center run by the community. And it was a beautiful, beautiful system. Because if somebody wasn't doing well, say they had slipped back into alcoholism, they knew who that person's uncle was, and they knew that person trusted their uncle. So they would reach out to that person and try to really help them. And it has much more to do with community support, which ultimately leads to health. When people feel loved and supported and included, you're going to end up with good health outcomes.
Yeah.
When you feel isolated and marginalized and not cared for and stressed, that health gets really, really poor. So just wanted to.
Thank you. I feel like we could have a whole other session just on community-based models of care and caring. But we're out of time. I want to thank you both so much for your time, for your knowledge, for your beautiful words and thoughts, and just really appreciate your spending the time with us tonight to educate us. It's been invaluable. I want to say that thanks to I thank our intrepid tech hosts, Nancy Brucken and Chris Buffington and Susan Woolley. This is the third program in our series of 3 devoted to America's healthcare system. Next month, we turn to a new quarterly focus on voting systems. Our first guest will be Professor J. Alex Halderman, one of the top voting security experts in the nation. Professor Halderman will speak on voting system technology, facts, myths, and fixes. Look for details via email on our website or on our Facebook page. That's lwvannarbor.org and facebook.com/LWVAAA. I'd like to say that we can change the healthcare system through our votes. So let's do that. We look forward to seeing you on March 10th. And thank you again for your time and your expertise and your kindness. Take good care.